What if I told you that in 2025, the way we access and exchange healthcare data will be fundamentally different? For years, we've talked about interoperability, but now we're actually seeing it take shape. Nearly 40% of the CommonWell network and most Q-HINs are responding to patient access requests, opening the door for a new era of seamless, secure, and patient-driven data exchange. Is this a bright spot or is this just the beginning? Today, I'm speaking down with Paul Wilder, Executive Director of CommonWell Health Alliance, to explore how Q-HINs, TEFCA, and emerging health data marketplaces are changing the game. We're going to tackle the big questions: what's working, what's holding us back, and how health plans and providers can position themselves for success. If you care about the future of healthcare data, and I know you do, this episode was produced for you. Let's dive in. Hello, everyone, and welcome back to Bright Spots in Healthcare. This is Eric Glazer. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations around the land. Our goal is to identify as many of these ideas, these bright spots as possible, so that you can determine if the ideas shared during this very episode can be applied at your organization. We believe this strategy of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. And I am here with Paul Wilder. He's the Executive Director of the CommonWell Health Alliance, one of the two most prominent HIEs in the country. Is that a self?
That's accurate enough. Yep.
Okay. And I want to start, Paul. So first of all, thanks for doing this. Thanks for coming on the show. An in real life interview. I don't get to do a lot of these, so it's always exciting. I want to start with talking about 40% of the CommonWell network and most of the Q-HINs organizations that responded to patient access requests. You got a 40% response rate this past year, at least according to my information. Yeah. How do you envision this trend evolving in 2025? Are we going to continue to get better? I know there's some little, I don't know if the political changes will impact that, but just let's get into that. And then in doing so, let's talk about what sets CommonWell apart from the other healthcare data exchanges.
Yeah, I mean, we know that patients and providers will do better as partners if patients have data. Like, that's an obvious table stakes thing. We know providers will do better with more data. So you kind of look at 40% and say, is that good or bad, right? Is 40% a bright spot, or is it 60% we don't have done and we got to get there? And I think you have to look at the 40% as a bright spot. Like, you go backwards. The main thing that we found is, yes, everyone believes it's important, but what are the risks if I do it wrong? Right. And I think the reality is, if we all started businesses always talking to the lawyers first, we would never start a business. Right. They'd say you need 7,000 insurance policies. And by the time you're done, you're like, I can't open a business because someone might slip the second they open the door. But you got to take that risk and move forward. And in this case, providers giving data to patients without friction, as frictionless as possible, does have some headwinds in terms of risk and asymmetric risk. And giving data to the wrong patient could be a disaster. Giving the wrong data to a conglomerate of disasters could be a big disaster, right? You don't want the mafia owning a bunch of someone's healthcare data and not knowing it. So we get the risks, right? So how do you get people to move forward? Like, you got to find people to start doing it and find out that the risks are unfounded. Right. This isn't skiing down an Olympic course when you're a beginner. You don't do that. But eventually you do when you understand the risk and you get better at the skill and you get moving. So it's about getting moving and getting momentum. And we're proud to see that we're on the bright spots out there, making sure this gets done.
Could you get more specific with this? So I get the risk of giving the data to the wrong patient by accident. And I could see that being you can mitigate that risk, my guess is, within the operations of a medical practice. What are some of the other risks?
Well, the risk of not moving to me is bigger than the risk of moving. I think that's that's the hump you got to get past.
I agree with that. So when I'm trying to ascertain, like, what are the risks of my physician giving me my medical data, other than maybe giving it to the wrong Eric? Like, I want to understand some of the other risks.
The reason why that question is incredibly interesting is no one seems to know the answer to that. They just know they're afraid, right? It's like the first time you ride a bike and your dad lets go and you're able to ride it because you're not worrying about the problem anymore, right? You got to get past saying what can go wrong and say, why am I not doing this? And so the things that could go wrong that people are worried about are getting sued, right? Flat out getting, my data was breached and you did it. And there are so many things we've done, so many various, both e-commerce and others, that we embed trust in the process. And healthcare has a problem with trust, right? It just has a problem of, I don't know what's going to happen. And when I don't know, I want to say no, the other version of that no. And we just got to move past that. What we found is data does help a little bit, right? So saying, here's how we match records. Here's how we make sure the person is who they say they are, because that's important. I can't give you your data if I don't know you're actually Eric, right? That's not, well, maybe you could bring me a piece of paper saying my mother has the right to my data and I've signed that away. And that's helpful. But we need to know you are who you say you are. And then we need to match the records. And I think the reality is that we weren't sure what the records were. Also keep in mind, a lot of these databases go back decades. And old data wasn't designed to be shared this way. So they're not sure what their own stuff is. The average hospital, without trying to offend anybody that works there, the second lowest paid person at the hospital is responsible for all the patient matching. It's the person at the front desk that takes your name, address, and writes it onto a form and keys it into a system. If that person messes up, some bad things can happen downstream. The question is, what are those bad things? No one knows. No one's been sued for this stuff. It's never happened. So why do we keep worrying about it?
So did you just mention, I was going to ask you the next question was like, how are you overcoming at CommonWell some of these obstacles? You had mentioned sort of, how we match the records, creating a process for that. How do we determine we know who you say you are? And obviously that's basic stuff we all go through as consumers, not just in healthcare, but anywhere. Any other things that you're doing to sort of overcome those obstacles and facilitate more data exchange?
Well, data exchange between providers have been increasing at an exponential rate. Exchange from a provider to a patient is not. And part of that, there's two reasons, right? One is because the providers weren't providing the data, and that's where the 40% comes in, and it's great, it's 40%, let's get it to 100. The other side was patients weren't sure if they were interested in this stuff, right? So some of it's demand creation, making sure the patients show up and demand that they get their data. And I entreat that on everyone. The main reason to get it, by the way, is not necessarily for better clinical care. Part of it is just data hygiene. Here's a reality that we don't think about. Electronic health records have a bazillion errors in them. And the amount of errors can cause serious harm later on that you should be aware of. And so it's partially a one-by-one conversation. I'll give you an example. I got a flu shot last year, right? According to my EHR, I had HPV vaccination. Not many 40-some-odd-year-old males get an HPV vaccination. Now, you say, who cares? The doctor's going to look over that data and skip it. But what if some AI tool in the future with some amazing prostate cancer medication cure skips over my record because the AI saw that I had HPV vaccination in my record and it's contraindicated to that drug? I'm not going to get that anymore. People have to look at their stuff and make sure it's right. You wouldn't just not look at your credit card receipt and pay for everything. Like you'd say, I didn't buy a TV at Best Buy last week. This is not my $3,000 charge. People need to be more interested in just what it is, not necessarily what to do with it.
100%. My doctor's great, but when I go into open notes after an exam, I often catch small little inconsistencies and correct, and he thanks me and corrects them. And
you have a great doctor then, because the law doesn't actually require them to listen, which is amazing.
We set the record straight. So I do it, as much as I go in for the appointment. And I actually get alerted that my open notes and my record's been updated to prompt me to go in there and check it. So
that's great. Now that's a good provider, because the actual law says you have the right to request a correction to your record. It does not say the provider is required to listen to it, which is pretty amazing if you think about it.
Let's shift a little bit and talk about the CommonWell Marketplace, because I don't know a lot about this and I want to hear a little bit more about it and maybe how it's going to affect health plans and providers who are listening. So you introduced it back just a year ago, 2024, and it's in the building and testing phase.
Yep.
Share the vision behind it and what kind of progress you're making.
Yeah, the other thing we've noticed with data exchange, first, we're exchanging a ton of data, right? A ton of data is flying around. What we're not sure of sometimes is how useful it is or how much it's being used in clinical care. And what we've observed is that it's kind of a fire hose problem. Like people connect up to CommonWell, there's 34,000 sites, then we're connected to frameworks that have another 70,000 sites, and 1 billion documents a month are flying around. And it's so much data, you don't know what to do with it. Right. And that's just the reality is providers don't have a lot of time to look at data screens and extract this stuff. They want insights. Data and insights are different things.
Actionable insights is a lot more easy to understand than.
Yep. Even analytics. Analytics are like, well, that's still not an insight. That's just that's just putting things into number form, taking data and making it have averages. Yay. So 50% of the population is male. That doesn't help you know how to take care of them. That's just a fact. So what we said was, there are a lot of tools out there. We're at Vive right now. You look around, there are all these companies with a lot of neat things they're doing that aren't getting to market, getting it to the scale they need to get to. Let's help them get to that scale. So if you have a great widget that can take this voluminous amount of data and put an insight for a male diabetic with a history of high blood pressure, whatever, that's unique to that, rather than you being a tool sitting on a phone trying to sell it to one patient and one provider at a time, put it on the scale of a thing that's already hitting 80% of the data in the country, and let's give insights to everybody. So the idea is the marketplace allows them to plug in as extra service providers. We don't touch data, we don't manipulate it, but we'll allow other people to do that on your behalf.
Okay, so explain this. So on one hand, I was thinking, okay, this is very cool. You're almost helping unofficially incubate some of these cool tool companies that we see on the exhibit hall and beyond. But now it's almost, the more you talk, it sounds like an app store for like HIE or am I getting it both right, or is it?
Well, it actually is. So we have an example. We have an EHR member, great member. They have a 10,000 to 1 ratio of the number of documents they give out to the market versus the number of their providers get back. Right. And the reason why is their EHR, while it's a great EHR, doesn't do a lot of great stuff with the external data. It doesn't. So when you get a piece of data about you, you may have gone to 12 providers in the last 20 years. A lot of your data is going to be duplicated. Like your appendectomy is going to look like 20 providers did an appendectomy. You only had it done once. So the data that comes back when it's not deduped, normalized, restructured, will make it look like you're taking a bottle full of aspirin every day. But it's really just the same data coming through multiple sources saying the same thing.
Sure.
So organizing that data to present in front of a provider to give the summary view faster allows them to work with data that before they were putting on the side because it was too voluminous to go through. So I wouldn't say it's necessarily an app store. It is a way for technology to assist those providers to accelerate what they use with this data without necessarily all these EHRs having to do it themselves, right? So it shouldn't be every EHR has to be a master of every ology and every type of data. Someone else has that niche thing. Let them plug in and help you do it.
So who's making the decision in the marketplace to use a particular tool? It's the member EHR, or is it the CommonWell Marketplace, or the CommonWell organization themselves, the alliance?
The model we're envisioning is the providers themselves, right? So it could be
the
patients.
Providers. So not even the EHR, the providers.
Correct.
How will the providers have the chops to know what they need?
Well, the reality is that from just a distributor, wholesale, all that kind of stuff, the EHR is going to be the ones that have to present the options that work within their ecosystem.
Okay, so we're going to let's a real example and use names. And
Sure.
I'll use
Sure.
Let's say you're off and I've been seeing 20 providers over the last 6 years, and my hospital system and my PCP just moved on to Epic. They're a smaller EHR company. I'll introduce you to them. And
Heard of them.
And so in my medical practice is looking at all this, and just like we'll use the example. It looks like I haven't. Let's say I had I had surgery for a hernia, and it looks like I had that 5 times because it's been replicated by 5 different doctors when I go in and see. Who's making that decision to find the right tool to go into Epic and clean that up? It's not my doctor. Is it someone at the Beth Israel Leahy that's going to like an IT person?
Correct. It'd be an IT, CMIO, Chief Medical Information Officer type that would say we need help.
Okay.
And by the way, this data, it's not that hard to figure out if you do it, but you have to do it, right? Most of the data is tagged this event that, your hernia it happened on January 12th, whatever year. And it's all tagged with the same information, or at least a ballpark, right? You'll say to your doctor, when did you had a hernia operation. When was it? About 5 years ago. That's close enough, right? When you have 5 things that all happened in the same vicinity, you as a human look at this data very quickly and say, oh, that's all the same hernia. We get it. But when they're running fast, like how long does your average primary care provider visit? 6 minutes, or that you actually see a doctor? Culling through all that data is kind of hard. And they're looking for complicated things now of what are the contraindications? What are the multi, are you diabetic with high blood pressure, or have you had a hernia? Have you had you got to look at it all together. This helps highlight and bubble those things up a bit faster. So it would be the practice. It would be the hospital system or the primary care provider that would say, for my practice, we want to add that tool.
Okay. By the way, everyone listening, that hernia information is private information. Let's keep it between us. All right. So how do you, I love it. So where does the marketplace look like a year from now? And then follow-up questions. I know we're kind of a little bit tight on time here. How do you see the role of CommonWell and your peer HIEs leading the charge for improved patient access and to try to get more EHRs to join and be part of all this?
Yeah. So first of all, CommonWell original mission was to connect everything together, right? So think of a utility, right? You have water mains. Let's get all the water mains laid and make sure our water is flowing.
Yeah.
And when you came to me and said, I want to hook up to CommonWell, but the data is kind of messed up, you're like, well, we don't really make faucets yet, right? That's not our deal. You pick your shower head. We're just going to get water there. We're a utility. We're flipping that now to say, we're going to help you get better faucets, because we recognize that now we sent a bunch of water into your house. Maybe it actually needs to hit a bathtub or hit a sink. It can't just be spraying everywhere. So we think this is going to accelerate people being able to logically use data. And CommonWell itself, the main thing it brings is scale. I've been doing this a while. We have an incredible trust framework. People that trust each other want to exchange data and do things at the right way with the right data at the right time for the right provider. And I think that's a big deal. So now you can inject good tools at scale to tens of thousands of entities that need help. And for some for help they don't even know they need yet. So the marketplace gets to highlight ideas too. Now you say, did you know that there's a diabetes analysis tool that's in line to exchange? You do the normal thing you're doing, and where normally you'd get 20 documents back, you're going to get 21 now. And that 21st one is going to be specific to the kind of thing you're interested in. Are you going to ignore the other 20? You could just look at the summary. But if you want to go back to the original references, you got those too. So you kind of get a little bit of both. You get better summary views, and you get deep data when you need it for the things you need to know to look for.
Okay. Last question. So for the leaders at health plans and hospital systems who may be listening right now, given everything you just said about the evolution of HIEs, given where you guys are going as one of the pioneers and drivers of change around information exchange in our space, what's the takeaway for everyone listening? Like, what should they be thinking about in 2025 and beyond, whether they're in value-based care partnerships, whether they're in a clinical role, whether they're in a role helping do predictive analytics?
Well, I mean, first of all, my main thing is keep going, right? We're unapologetic about the amount of data. I've actually, unfortunately or fortunately, been tortured by regional associations telling me to stop hooking things up. There's too much data. And I said, look, guys, I can't. Like, the fact is that the small piece that's missing might be the most critical piece. I think we're moving on now to, sorry, we're not stopping. We are going to continue. And now we're going to help you highlight the things that you were missing, right? Because you don't know, 80-20 rule, 80% of your data may be available. The important stuff might be in the 20% that's left. And now when we hook that stuff up, we're going to bubble to the top, make sure it's known, and get better care for patients. And hopefully, bend the quality cost curve and the stress curve, right? Providers are stressed trying to get through all this stuff, and let's help them get it and do it better.
Love it. Paul Wilder, Executive Director of the CommonWell Alliance, connecting everything together. Thank you for all the insights. I know we were tight on time. Thank you all who are listening for tuning in. We do not take the time you spend with us for granted. We hope you use the ideas, the insights from Paul today, to inspire your thinking and enhance your company's current approach to improving healthcare. For all of us, we produce this show for you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.